Now we're going to see closed angle glaucoma. This could be acute or chronic. This is due to decrease in anterior flow of the aqueous humor in the anterior chamber, or some problem, let's say lens dislocation or increase in the pupillary dilation. This could be due to increased stress or medications or increased time spent on dark area or family history or age more than 55 or 70. This would lead to decrease in the flow on the anterior chamber that leads to accumulation of aqueous humor on the posterior chamber, and then this pushes the iris against the cornea because there is increase in the intraocular pressure, and this closes the angle between the iris and the cornea. So there would be decrease in the trabecular meshwork drainage through the Schlemm canal. This, when present as acutely, present as a emergency because the patient could lose the vision, so it's an emergency. We need to do ophthalmologic evaluation immediately. And the patient besides it will have a red, hard, painful eye. And the pupils would be fixed pupils that do not react to light. This would be one of the things that would distinguish anterior uveitis, because in anterior uveitis the patient can have also red, painful eye, but the pupil would be constricted and poorly respond to light. If it is chronic, this would be secondary to hypoxia. Hypoxia could be due to diabetes mellitus retinopathy or vein occlusion. That would lead to neovascular proliferation. For example, in diabetes mellitus, there would be a neovascular proliferation that at the end would produce angiogenesis on the iris or between the iris and the cornea, and this would close the angle. So the emergency is the acute. This could present, for example, in a patient goes to the movies and when the lights are turned off, suddenly the patient develops this red painful eye and fixed dilated pupil. This is the emergency, and all the medications that produces mydriasis are contraindicated. Or sometimes the patient is taking, for example, some mydriatic medication, and after this, 1 day after this or something like that, would present with this acute presentation. The treatment is to decrease the intraocular pressure. We will do this immediately by giving IV intravenous mannitol or intravenous or oral acetazolamide. If this doesn't work, sometimes we can do peripheral laserectomy, that is to produce a hole in the iris in order to increase the angle. This could also be done prophylactically, or sometimes we can do trabeculoplasty. Now the diagnosis is, and also things that we can do is to increase the trabecular meshwork outflow drainage. That would be with pilocarpine or carvedil, for example. Now the diagnosis is made by goinoscopy. Goinoscopy is the gold standard, and this is we will put a special cylindrical triangle that will allow us to see in a slit lamp examination to measure the angle, and we will see that the angle is decreased. This is the gold standard. But if we cannot do this on the emergency department, we can do tonometry. So the best initial test would be tonometry, as in open angle glaucoma, in which we will measure the indentation that results from putting measure pressure against the cornea. And we will see certainly also sometimes the cup optic disc ratio increased, and besides this, the patient can present also with nausea, vomiting, flashes, and the cornea will have a hazy appearance.